ultimately is for the benefit of obviously the patient. That's where everyone is centered. So what I want to explain to you is really, don't focus on too much of the science stuff, but there's two types of ECMOs. One is VA, which is veno-arterial, and the other is VV, veno-veno. And that really comes down to how the patient is hooked up and supported. And there's reasons why you would do different ways according to the patient needs. Another thing that you need to, first thing you're going to kind of have to know and how much support we're going to ask from you is if it's VA and if it's VV. The second thing is, depending on where the patient started, sometimes the chest will be open and they might just have kind of like a fake skin. So you're literally going to have an open wound. For you guys might not be that big of a deal, but when you have all this support, you're going to be losing a lot of volume. We're going to be having more people with us. As much as you are with us, we will always have at least a perfusionist, always. We'll have you guys, many times I ask for 2 crews, and that's literally for manpower. We always like the big rig. I heard the big rig is down.
It should be coming back soon.
Okay, so that is a huge problem, but we have ways to work around that because of all the support.
We should have it back this week.
And we'll always have a critical care nurse because I can't do it all and you can't do it all, and they need to run all the pumps. So when you run into someone, you say someone's on ECMO, some things to keep in the back of your mind. The reason they're on ECMO is the ultimate goal is to get them off of ECMO. Patients that go on ECMO, the hope is that they obviously will be able to come off. These are patients that are either going to be a bridge to transplant, their heart needs time to rest, their lungs need time to rest, and things like that. So at the end of the day, there are contraindications, but when you show up, this is not a 1-2 day support. They're going to be on these type of machines for quite a while to kind of help heal the underlying problem that they're dealing with. At the end of the day, it's a machine, kind of like flying a plane. Everyone's like, oh yay, I'm a pilot, whatever, I'm a perfusionist. The plane is actually flying, the pilot flies the plane. We are all here, the surgeon, perfusion, everyone is a collective team. We are managing the ECMO. We are flying these machines. And so it's a very critical, just as I brought up some small samples of small little things that make a difference, the little red lights, you guys all know how that works. So you have that ability. Talking about the difference between ECMO and ECLS, the terms are many times used interchangeably. The true difference is one is the ECMO, which is the membrane oxygenation. That is truly when we are taking over the full function of the heart and the lungs. There is a pump that acts as your cardiac output. In other words, compressions, we're pumping for your heart, and the oxygenation, we are your lungs. The ECLS is more a term that could be used when you're doing more VV, which is more just support of the lungs. It does provide circulation, but how you're hooked up and how much we're actually asking the patient to contribute as well. Those terms are used kind of interchangeably. It does not make a difference to your guys' world. It's more of a medical term and small changes that we are having the patient contribute to as well. ECMO altogether is temporary, and it is truly a bridge. On adults, they don't do quite as well long term. Many of them don't make it, and they do die on ECMO. Either of a complication of a bleed, of a brain bleed, of the underlying problem we see is not resolvable, but we have given them the best chance. Pediatrics, if you do any pediatric transportation through children do very, very well. And then again, their underlying issues are different. It's a bridge. It's a bridge to get them to go off ECMO and be able to support their heart and lungs again. That's the ultimate goal. How long can people stay on ECMO? Because you're going to be there in the beginning, or they've been on ECMO, maybe you're at an outlying hospital, and you're making the transfer. By the time you get there, either they went on that day, maybe 3 to 4 to 5 days in the facility. It's like, we can't do anything more. So we need to go to the big house or another big center. People can stay on ECMO 1, 2, 3 months till either A, they get better, B, all the mechanical support has its limitations as well and they outlived that, or 3, a complication happens and they terminate. So it is not, it is a bridge. And then if ECMO doesn't work, you might hear the term VADS or other type of mechanical support that will get them on to the next step. The physiology, as we said, it's basically, we take over heart and lungs, we talked about that. We have a membrane, we have a lung, just like anything else. We can put in oxygen, we blow off CO2. We're not gonna make this overly complicated. So we deliver, quote, red blood to the patient. That's what they need because they don't have the ability themselves. At the same time, we're providing circulation. So we are trying to enable, make sure that just like everything else, the brain, the kidneys, every other body organ gets the perfusion that they need. And it's that simple, but that's not that simple to deliver. So what underlying diseases are we treating? We talked about VV and VA. VV is veno-veno. And what that means is how you're hooked up, pretty much. So that means on a venous site and a venous site. So it is pretty much blue blood circulating around. These are mostly patients that have really bad lungs. In the last couple of years, everyone heard about H1N1. And everyone was freaking out. And these were young people in their 20s and 30s that would be in respiratory distress with H1N1. And it was really a shame. We saw a huge increase in ECMO because their lungs were shot. And those lungs just needed time to recover. They would go on ECMO. Sepsis, you have a patient in the hospital forever, they end up being septic, they need time to recover, but they cannot support themselves. Will get called and those patients will go on VV ECMO. Why? Because the heart can pump on its own technically. It has the ability to pump. So that is more of a VV, of a lung help that the patient needs. And the VV ECMOs usually are on a lot longer. The lungs take time. And when I mean time, they take time to recover. You just spend an hour talking about just ventilation. Lungs are very fickle. And then they get filled with junk and crud and everything else. And then, you end up with a pneumo or this and that. Lungs take time. So those are VV. These are acute respiratory distress syndrome. And you have chronic lung disease many times. You have a cystic fibrosis person. They might end up on ECMO hoping at the last-ditch effort before they would get a transplant. Some of those are contraindicated depending on where you're at. VA ECMO, veno-arterial, when you come into that, and the reason I'm telling you this is it makes a difference by the time you arrive. VA ECMO involves the heart. That pretty much means the heart needs to rest and the heart is not working, along with the support of the lungs. Usually that means that crew, those nurses, us, we've probably been in the operating room all day, half the night, working on this patient. They were not able to come off the heart-lung machine, and we put them on ECMO. In other words, the operation was a success, the patient is not doing well. So they go on VA ECMO. And what we're hoping in those circumstances is the heart just went through a huge operation. It was very, very complicated. There was probably blood loss and products and everything else. That patient needs that, and that heart, that muscle, needs time to recuperate. So literally we're trying to buy that time. Those patients that are on VA ECMO, you're going to expect a lot more bleeding, a lot more volume support. Their hemoglobins are going to be low. So there's a lot of other factors that are coming into that. I've been on a case where I got called up to the unit. I was not at this hospital. It was a 33-year-old morbidly obese African American lady, had a gallbladder, which is 3-4 months postpartum, typical gallbladder. It's kind of when that happened. And we get called up to the floor. She got up, went to the bathroom 3-4 days post-op, literally collapsed, went into cardiac arrest. Well, you're not going to let a new mom who just had gallbladder taken out, go. We got called up, we put her on ECMO, supported her, figured out what happened to her. 3-4 days later, she was off ECMO. A week later, she went home. What happened to her, we don't know. Was it truly a PE? Was it just some SVT that went wrong? We're not sure. So those are situations where you have a sudden cardiac arrest. We get called to the cath lab. There will be times I've had you guys come in directly to the cath lab, we put them on ECMO, and we're going straight to the big house. I've had you guys come into the operating room where it was VA. We did heart surgery all day long. Things didn't go well, like I said. We put them on ECMO, and we're going to go straight. You're going to be called up to the unit. We got them out of the OR. We went upstairs on ECMO. Now we're waiting and trying to get all the missing pieces in order, and now we're going to go. So those are the kind of some components to take into consideration. So is it like being on the heart-lung machine on bypass that I talked about in the operating room? Not exactly. Let me give you an example of what I deal with in the operating room. This is a schematic of the heart-lung machine. So if you would ever walk into the operating room, you see a patient on ECMO, you're going to see a huge machine onto the side that looks like spaghetti. And just to kind of give you an example, really all it does is take an over function of the heart. The heart's very complicated. So there's all these things that we are dealing with regarding volume, shed blood, volume changes that's coming back to the patient, turning blue blood red. This is the most complicated mechanical CPR in a nutshell that you will ever see. And that's what we do in the operating room. So that's the heart-lung machine. You transfer that into a much smaller version, take over to the patient, and you get ECMO. ECMO's going to look something kind of like this. You're going to monitor pressures, patient pressures, your blood pressures, because I am taking over just like you're sitting there pumping out, you have a blood pressure. Well, artificially, you need a blood pressure. The difference is with ECMO and bypass is you all know systolic over diastolic. So you have a 120 over 80, let's say, of a blood pressure. This is artificial. There is no up and down. You have a straight pressure, you have a map, you have your mean arterial pressure. So many times they say, what is the pressure? You're going to say 65. I'm going to know that 65 is probably 90 over 40. That's all we can do. That's all that we have the ability to provide because it is an artificial pump. We cannot give it that pulsatility. Pulsatility is good for the kidneys, by the way, and that comes into play later. We have an artificial lung. Here's an example of an artificial lung. So that's a membrane. I'm going to show you one in a little bit too, the one that we use. Here's your pump. Here's your cardiac output. Then we're going to monitor your venous saturation. Ultimately, that's your true goal. Doesn't matter how much red blood you give, but if your blue blood is black, something's not right. So I can give you as much good support, but if the patient is not taking it in, just like you know with the ventilator, you can be ventilating, but if it's not working because you don't have good lungs to work with, you're in trouble. Now, if you are taking a patient's circulating volume and taking it outside of the body, it's going to get cold. Also, probably not good for overall body functions. So we have a way, and we warm the blood up so that they are actually warm. On a very rare occasion, you might have a patient who was a drowning victim. They were cold, they're doing okay. They would call us, we'd put a cold drowning victim on ECMO because now their lungs are shot, they can't breathe, they need time to recover. Another situation where you might walk in and say, what's the history of the patient? Was a drowning victim. And we got them on ECMO, now we're going to transfer. Same type of thing. There, you would start cold and warm them slowly up in those situations. What do we always have with us? We're always going to have a backup battery because if our system goes down, that's really bad, to put it that. And an anticoagulation device. You guys know what ACTs are? Have you heard of an ACT? Any idea? Okay, an ACT is an activated clotting time. We're dealing with blood. So these are terms that you're going to hear. Activating clotting time, because we're dealing with blood, is we have to give heparin. We're taking the patient's circulation and circulating volume, and we're putting it into something that is foreign and artificial. It is natural for the blood to want to clot. Just like if you're going to form a scab, you're going to you're going to bleed, whatever, it's going to dry out on the table. We're taking it outside of circulation, so therefore we have to have it anticoagulated. Otherwise, all these systems are going to clot up, get gelled, and not work. So many times before we leave, someone, usually me, will ask what was the last ACT, so we know that it's high enough because we're going to be on the road for a half hour to 45 minutes to 1 hour. And the fact that by the time you get there, you want to make sure they're still anticoagulated, because it would be really bad for all these systems to clot off and just come to a stop on the way. If you are on VA ECMO, like I said, we've been in surgery all day, those patients are usually so well anticoagulated on their own because they have been in surgery all day. They've got a ton of medications. They've been transfused units and units of blood and FFP and platelets and everything else. Those are situations that they don't get a lot of anticoagulation, but the conversation should be had. These are different systems of ECMO and ECLS. You will see one. This is a cardio health. This is a different type of lung. So they come in all shapes and sizes. I brought ours in the back. I'll have you take a look at it and just the different components, because these are just things that you need to kind of go, oh, why is she so protective? Or, oh, don't let that kink, because that's the motor. So I want you guys to eventually have an idea of this is the motor, this is the lung, this is where this is, because those are the critical components as you go. This is a system that some of you might have seen. This is the one at MOVAC, because I was there forever and did a lot of ECMO training there. Basic that every system's going to have. Here's your cardiac output. This patient's only getting supported by 2 liters. And you're like, oh, well, what's this machine? You always have a backup. So in that event, you'd literally move the motor from that side to this side in less than 6 seconds, and you can take over. So you have backup, you have oxygen. This is, we call it sweep. This is our oxygen diffuser, for lack of a better word, where you deliver the FiO2 and blow off your CO2. And we dial that in according to the patient's needs. The difference is we have full control over what we are delivering. Okay? And then you have the lines that would go. Again, basic components to the ECMO. How are you going on? You're going to have a centrifugal pump. It looks like a cone, and that's the motor. That's your cardiac output. Usually at any point, the minimum that you're going to run is 2 liters. You got made fun of that you were 6'2", and the other guy got made fun of that you were not. Someone got made earlier today. The demands of each patient are going to be different. So a larger person who's either taller, or, if they're young and really muscular, as well as I do, but minimum, no matter what, will be about 2 liters. The reason why it is a motor, just kind of like a car, you have to have basic RPMs to stay on. If it turns off or stops, you have sitting blood, it's going to clot and it's going to stop working altogether. So even on an adult, even someone that's really small, you want at least 2 liters. A lot of times you're going to hear, oh, we're chugging, or we can't flow, and everyone's working to try to get that flow up. That's where, hey, I need you to squeeze some volume and go help the nurse. Hey, take a look, now where are we at? There'll be a lot of eyes asked upon you of, hey, what's the pressure? What's my flow? What's this? So more just to give us the information, because there's so many components and small things that are being monitored that we need your eyes more than anything, because we can't watch it all, especially in a tiny little ambulance or down the hall. You just can't see it all, because you also have this patient that's in the middle that takes up some room. We talked about trying to keep the patient warm. On transport, we usually don't. We have to make sure that's disconnected. The reason why, it's another huge piece of equipment. That's really the only reason why. If you're going further, you might. And then obviously the oxygen. What is the basic principle? I think we kind of covered that. Deliver gas. That's it. And support and circulation. Gas exchange, leave that to us. Not a big deal. Concentration of the higher blood gases up the side of the membrane. That has to do more on the artificial lung and how we are manipulating to get that done, and how much CO2 is being blown off. So when can you see it? Well, we talked about this a little bit earlier. Respiratory failure, cardiac failure, and what are their goals? If you're in respiratory, you had that, severe pneumonia, you had that H1N1. Literally, just get oxygenation, get those lungs to start to work again, and give the lungs time to rest. We said how fickle they are. Cardiac, we want to make sure that you get native blood flow returned to the patient. They can't do it on their own. When it is both, those are long-term, and then that emergent that can't do CPR, preserve the brain. We don't want them brain dead. We come running in. Contraindications. When you guys are doing CPS, and I'm sure, or CPR, you guys have heard it, and you have to make the call. Someone shows up and says time of death, right? Kind of sucks. Now that you know that we have this ability, you might be asking, why aren't we putting everybody on ECMO? Really? Right? You're showing up, you've been doing CPR for 30 minutes. Well, call perfusion, put them on ECMO, let's give them time. Right? Not a bad train of thought if you really think about it. But are they recoverable? What was the underlying process is really what it comes down to. And can we get there in time? If you've been doing CPR for an hour and you guys are sweating, whatever, it might be assumed that brain damage has already happened and they're not going to recover. At least in a more controlled setting, we can get there and give them the best chance. If there is no cure, as we know, let's say we're in the operating room and you're going to put them on VA ECMO, and the goal is, quote, to get better. And that's when I said surgery was a, quote, success, but the patient's not doing very well. On a very, very rare occasion, we could say surgery was not a success, and therefore the patient would never do well. Those patients don't get ECMO. Make sense? Okay. Why adult ECMO? Something acute happening, life-threatening. We're hoping it's reversible. Sometimes we don't know. And conventional therapy, we've exhausted all medical therapies that can be given. They are maxed out on pressors, they're maxed out on drugs, there's no more, epi, dopamine, dobutamine. They're kind of at the extent of making the patient do what the patient can do themselves, and now they're gonna have us take over function and kind of balance that out. Patient with cardiomyopathy, a big balloon, kind of a rotten, ballooned out, lazy heart muscle that, depending their situation, we're hoping to recover. Cardiogenic shock, those are when you guys get called, you bring them to the cath lab, they're in shock. If we can get to them, we'll put them on ECMO. Maybe they just couldn't make it to get that stent open quick enough. We can come in and then post-surgery. The pneumonias, the H1N1s, and then some bridge to transplant, and that gets a little different. And they can't have any type of problem underlying with the anticoagulation.
That's a good question.
Yeah.
Does blood still flow to the heart and lungs?
Yes, it flows
During ECMO?
to the heart and lungs, which is the goal, but the heart and lungs don't have to do the work.
Okay.
So again, very good question, because your heart needs to, it's a muscle, it needs to still get coronary support and coronary flow, but the heart doesn't have to do the work to get it there. Same with the lungs. The lungs don't necessarily have to oxygenate, but they do need the blood to get there. So it's not doing the work, but it's getting the benefit. On the lung side, a lot of times, and we'll get there in a second, we will still have a ventilator on transport and up in the unit, but we might turn the rate down depending on the situation. Sometimes as low as 8, sometimes 10, sometimes 12, where you're thinking these people can't breathe and they have no oxygenation. We might have a high rate of 18 or higher, just at least initially, but the reason is we just want them working just to try to prevent atelectasis, not actually for oxygenation, because we're providing that. So yes, they're getting the support but not doing the work.
Okay.
Make sense?
Yeah.
Okay. When you would never see a patient on ECMO. So you showed up and badness happens, you're like, dude, why don't we call this perfusionist in? If a patient has metastatic cancer, again, quote, non-curable, we're not gonna go, because ECMO is very expensive. And when I mean very expensive, it's very, very expensive. If we know that there's already cerebral damage, they're not going to necessarily recover. We're thinking tests have been done, and we're thinking that they will never be able to take over those vital functions of the heart and lungs again. Depending on what's going on, if we start to see unreversible sepsis, we will get called core sepsis, but we see that they're not reversing. A lot of their labs start to go whack. Their lactate is going to keep climbing and climbing and climbing, and sometimes we can help reverse that, but if we see that it's not liver failure, not necessarily a big ECMO candidate, also acute renal failure, to have that. If you are bleeding uncontrollably, you have a gunshot wound, you have a huge a wound here, you're bleeding out. So this is a closed system. It's right now just like you and I, we're a closed system, we're circulating all around. You got a big hole somewhere in your aorta, putting a tube in and pumping blood all around, guess what? It's just going to come right out that hole too. That's not supporting. You can't do that. You're just going to bleed right out within your main vessels. So uncontrolled bleeding, you cannot manage a patient on it well. Aortic insufficiency. Understanding a little bit of the anatomy of the heart. If you have aortic insufficiency, it's the valve that comes up on top. That is where, right after that valve is where you get blood supply to your actual heart. So if we're flowing and it kind of ends up backing up into your ventricles and it's not going to be able to get to those coronaries and help that heart recover, those are not candidates. Usually pulmonary hypertension, where we see that the lungs, after if they have chronic pulmonary hypertension, if they're not going to come back, we don't put those people on ECMO. And also if the heart is really in a situation that we see it's not going to ever recover, then it's just what's the resources.
What's the availability like in your tertiary hospitals? What's the availability that's like in your tertiary hospitals?
So
like,
now in the last 10 years, a lot of that has to do with everyone's underlying problem is money. The reality is in the last 5 to 10 years, ECMO became very, insurance was reimbursing. So all these small hospitals, Christian, Columbia, little bodunk towns that have these smaller heart programs, or anyone that's doing caths that has some type of heart program, were throwing everybody on ECMO because they were getting reimbursed and it was a big money maker for the hospital. That's the reality. And the last year, we've had there's a huge increase because the H1N1 epidemic that happened about 5 years ago. Everyone was going on ECMO, and these 29-year-olds, and again, reimbursed. The last 2-3 years, insurance companies come down saying this is costing us millions and millions of dollars, because think of all the people that are involved, ICU, long-term, you're on ECMO for a month, you're in intensive care for a month, let alone the after stay and the rehab if you make it. So they start cracking down, it's not that reimbursable. Supposedly this fall, government and insurance companies got to get together, and there's something in the middle. So I think there's going to be an increase. The smaller hospitals, yes, because that's their only way of trying to save that patient, because they have two choices. Either you let the patient go, or you throw them on ECMO and try to get them to a center that can manage them, because they just don't have the people and the resources to manage those sicker patients. And that's where you're going to see a lot. Our Christian included. We'll be in the operating room, we'll be upstairs, we'll put them on ECMO, and we will transfer. And the reason we transfer is there's only 3 of us perfusionists and a nursing staff upstairs in the intensive care unit. If I'm sitting with an ECMO patient all day, and then, let's say 12 hours, and then Mike sitting there all night, well, I need to come back during the day. Mike needs to go and sleep. That leaves one person. Well, we have heart surgery to do. So if we have someone in ECMO in-house during the week, we literally have to shut down our heart program and cannot do heart surgery to support that one patient. So we are pushing, we push and we tell our surgeons, if you're going to put this patient on, we have to transport. And right when I get that, yeah, we might, I'm already on the phones or making people to call you guys saying, look, within 3 to 4 hours, get the big rig ready, get the people I need, get your stuff together because we have to get rid of this patient. Barnes, on the other hand, has a huge ECMO program. They have trained staff, they have trained nurses, so when perfusion comes, puts them on ECMO, they take them up to the unit, and the nurse manages them 24 hours, and perfusion shows up and rounds and makes sure everything's okay. We're always on call in case there's a situation, but that's why, yes, all the tertiary outlying hospitals that have the ability would go the ECMO route and then ship them to a bigger center.
So just so that I'm kind of aware on the outlying hospitals, what's the minimum that they need in-house? I mean, would you say that they'd have to be able to do caths, or it's just like somebody could be brought into an ER and you say, you know, hey, this is a potential ECMO patient, and you know, ER doc could hook this up.
An ER doc, a really good ER doc may be able to. They probably need to be a minimum vascular surgeon that they would have to call down, a cardiac surgeon, and have a perfusionist. Many of the smaller outlying hospitals don't have perfusion at all. Those centers don't provide ECMO.
I'll hop in. So
Yeah.
there is maybe, let's say 10 hospitals in the United States right now that are doing emergency physician initiated ECMO, and then transferring it to a perfusionist, cardiac surgeon, cardiologist. Generally it is in the intra cardiac arrest or immediately post cardiac arrest for those indications, cardiogenic shock, or we think this person has the chance of surviving if we can get them alive to the cath lab, or to do cardiac bypass or something like that. So there, you'll see these articles every so often of cardiac arrest patient got put on ECMO by the emergency department. You'll even see there's 2 or 3 famous photos right now floating around Europe from a patient in the Louvre getting put on ECMO in front of world famous art, because they have EMS physicians trained in initiating ECMO on that small, what was your small pump called? The transport one? The one that you got on the photo on the right.
ECLS?
No, the brand.
CardioHelp.
The CardioHelp. They have CardioHelp devices in France that they can start ECMO, get them basically put on pump, and then transport them to the hospital and figure out what's going on there. So this is very bleeding edge, cutting edge stuff of like testing the waters and figuring out who the right person is, what right patient, what right staff is needed to do that. We aren't at that capability yet in this region to do intra-arrest CPR unless it happens on the cath lab table or in the OR. We aren't even at the table to talk about it yet, at least at Barnes, but we are talking from the ER. We're trying to figure out who from the cardiac surgeons we need to talk to say, would you be willing to have a program like what I was just describing, to where some staff puts the person, like accesses the vessels, puts them on a pump, and then turns them over to a perfusionist to basically